Today, Shalom Tuntab and myself, Alison Reid, will be providing a slideshow presentation on evidence-based guidelines for management of the paediatric condition Sever's disease. Throughout the presentation, we will briefly touch on the background and description of Sever's disease, the path of our research from developing a PICO question to ask, acquire, and appraisal of our research through to application and factors for consideration for treatment.
In 1912, the condition was discovered and first described by J.W. Severs as the inflammation of the calcaneal apophysis associated with muscle strain in the immature pediatric skeleton that results in heel pain, swelling, and walking difficulties. Sever's disease, also known as calcaneal apophysitis, is the most common form of osteochondrosis, a distinct group of conditions relating to the growth plate of developing children between the ages of 2 and 16. More specifically, Sever's disease commonly affects active children between the ages of 8 and 16, which was noted by James, William and Haynes in 2013 as a condition that presented on average between 2 and 16% of all musculoskeletal conditions in children this age in sport clinics. The etiology of Sever's disease is as a result of repeated microtrauma of the traction between the Achilles tendon and the calcaneal growth plate. Some of the presenting risk factors for Sever's disease include sporting and activity type. This may include jumping, running, and athletics, foot types and alignment abnormalities, in particular pronated feet. Other risk factors include training errors, weight, poor footwear, growth, and in particular tight calf muscles with triceps surae. Although these have been educated as risk factors previously, an article titled Sever's Disease, a prospective study of risk factors, found that they were statistically significant results. However, clinically negligible odds ratio of 0.93 was found. Some of the symptoms reflective of Sever's disease include limping, heel pain, pain in the morning and pain when in bare feet. A squeeze of the heel may also reproduce pain. Some of the differential diagnoses for Sever's disease can range from osteomyelitis to a tumour such as Brody's abscess, rheumatoid arthritis, calcaneal or metaphyseal fracture, or neural tension. In determining a diagnosis, clinical assessment, MRI, and X-ray may be used to assist a final diagnosis. An X-ray, however, may not always truly reflect the condition. Before beginning our research, together we developed our PICO question to ask what it is that we were specifically researching. The population group that we've selected is children with current Sever's disease. Our intervention, treatment for Sever's disease, versus the control, no treatment for Sever's disease. Finally, our outcome assessed for reduction in symptoms and pain. Combined, our question asks, in children with currently diagnosed Sever's disease, does treatment versus no treatment lead to a reduction in symptoms and pain?
In acquiring of the highest level evidence into evidence-based therapy and research studies into Sever's, we first used a library database with Pedro, Sinal, Medline, and Cochrane. In our initial searches through the databases, we saw general articles about Sever's and the etiology and risk factors. We then specifically applied our PICO question to find articles that had studied the difference in treatment interventions, and specifically treatment versus no treatment in Sever's. Importantly for our case study, we had to expand the search by using calcaneal apophysitis as well as Sever's. For the search, we used terms such as Sever's disease, calcaneal apophysitis, treatment, and intervention. With Medline and Sinal, terms were then joined in the search phrases with and, or, so that the search could be more refined to the PICO question. Similarly, with Cochrane database, the use of meshing terms was applied to again be more specific to the PICO question that was formulated. From the conducted search, we narrowed down our selection to 2 high-level articles, which included a systematic review of RCTs by James, Williams, and Haynes, and a randomized control trial comparing orthotics and heel lifts to no treatment by Perham, Jansen, Norland, and Kiasbo. In appraisal of the first high-level article we found by James, Williams and Haynes in 2013, we noted there was a Level 1 Sever study and Level 1 NHMRC study, which is a systematic review that includes RCTs. Overall, the study included 9 articles within its selection criteria, with 3 being randomized controlled trials. The review of articles appraised the level of evidence of each study that they reviewed with the Pedro scale. As with the Pedro scale, James, Williams, and Haynes took into consideration blinding, follow-up, and between-group comparisons. Lacking in this systematic review was a number of randomized controlled trials that they included. This was because, and as they stated, due to the limited high-level research that has currently been conducted, and therefore their inclusion criteria was limited. The study found that heel lifts and orthotics decreased symptoms and pain within children who suffered from Sever's disease, with a p-value being less than 0.01 and odds ratio not crossing 0, meaning findings were clinically and statistically significant and applicable. Unfortunately, in many studies that they reviewed, the intervention of heel lifts and orthotics were not isolated in assessment and co-tested with stretching and massage. Importantly, in their findings, they have highlighted caution in treatment with just heel lifts and orthotics due to limited research and further research and studies needed. In the second high-level evidence article that we found by Param, Jansen, Norland and Kiasbo, we used the NHMRC and Pedro as appraisal tools. In appraisal with the Pedro scale, it was found to have a score of 5 out of 10, which was in line with the result that James, Williams and Haynes found in their systematic review. It had random and concealed allocation, adequate follow-up and in-between group comparisons, but lacked on blinding of patients and therapists, which allowed for or increased the chance of bias. With the NHMRC appraisal, it was scored as a Level 3 Subgroup 2 study. The reason that it was not rated a Level 2 or 3 Subgroup 1 study was due to the non-blinding and again increased probability of bias within the results. For this study to be of higher level, it would have had to have used a sham therapy intervention, such as an insole, to decrease bias and test for placebo effect. The results of the study found that heel lifts and orthotics in the treatment of Severs was statistically significant in reduction of both pain and symptoms, with a p-value being less than 0.01. In applying the collated research and articles, a formulated application into evidence-based treatment has been formulated, revolving around the PICO question of, in children with currently diagnosed Sever's disease, does treatment versus no treatment lead to reduction in symptoms and pain? The 2 high-level articles we found indicated treatment being effective in reducing symptoms and pain. Both studies that were analysed showed results with comparison and p-values being less than 0.01. In both articles, it was discussed and highlighted that the best intervention in practice was to combine orthotics and heel lifts with stretching and ice therapy to reduce pain and symptoms. It was also noted that in treatment and diagnosis, a full biomechanical assessment was required to help determine etiology and risk factors and therefore treat the root cause rather than the presenting symptoms. In taking a patient-centered approach and clinical reasoning approach to treatment with a patient with diagnosed Sever's disease, it is important to consider cost, age of the patient, activity levels, goals of the patient, severity and duration of the pain, social history, and previous and concurrent medical conditions. Ideally, and as research has suggested, the gold standard treatment would incorporate heel lifts and orthotics with a strict stretching, massage, and ice regime. Importantly, when treating Severs, and like any pediatric condition, it is always important to have an open dialogue and the education is provided to both patient and guardians so that understanding into the condition and risk factors can be established. Thank you for listening to our presentation, and on the next 2 pages are the lists of references that we used.